first presentation, and that is by Colonel Vijay Sharma, who will be talking on should all cases of keratoconus be cross-linked. So that is the idea, to know whether every case who comes with a diagnosis of keratoconus should be cross-linked or not. Dr. Vijay Sharma.
Thank you, sir. Good morning, everyone. So I'll be discussing about should all keratoconic corneas be cross-linked and some basic concepts about the cross-linking. It was Wolensak et al. In 2003 who, while working at Technical University of Dresden, they came out with the corneal cross-linking, and it was named as a Dresden protocol. Their technique was named as Dresden protocol. Now what they did was they subjected an actinic cornea to a photosensitizing dye, that is 0.1% riboflavin, every 5 minutes for 30 minutes. After it was saturated, then it was exposed to a UV radiation of 370 nanometer with energy of 3 milliwatt per centimeter square for 30 minutes. Total 5.4 joule was delivered, and over a period of time it leads to increased number of cross-linking the covalent bonds between the adjacent collagen fibrils. This results in strengthening the corneal tissue, and also it retards or it stops the further progression of corneal ectasia. So after this Dresden protocols, over a period of time, many variations to this also came into being. The problems were, this is one of the most standard and most efficacious of the corneal cross-linking, but the duration of the procedure was quite long. It used to take full 1 hour for the patient in the OT to complete the procedure. And also it was an epi-off type of corneal cross-linking. So it used to be cause some amount of pain in the post-operative period. So then epi-on corneal cross-linking was tried, but the efficacy was not found to be as good. The main changes that came into the protocols were basically directed at introducing riboflavin into the stroma, or decreasing the total time for the cross-linking. So for decreasing the total time for the cross-linking, the accelerated corneal cross-linking came into being. But accelerated cross-linking, when the energy was delivered at a larger amount of energy was delivered for the shorter duration of time, it led to complete oxygen deficiency at that level, and the procedure became less efficacious. So that is why some oxygen supplementation have been described after that, and also pulsing the radiation was also is also being practiced now quite frequently, which will be covered in subsequent talks by the speakers. Iontophoresis was basically by delivering a low intensity electric field created. The riboflavin was penetrated. It can penetrate through the intact epithelium and reach the stroma, and then the corneal cross-linking was done. So all these procedures gave new dimensions, and also various new indications were included for the corneal cross-linking. In addition to ectasias, primary ectasia such as keratoconus and PMD, the secondary ectasia such as post-LASIK ectasia or non-ectatic disorders such as infectious keratitis, where a PAC-CXL protocol is followed, or a bullous keratopathy, chemical injuries, and TMD, all these cases the corneal cross-linking could be done. Some additive, it is also being done as an additive procedure along with the SMILE or LASIK as SMILE or LASIK extra, with the PRK as in Creighton protocol, with PDK as in Athens protocol, and also it can be combined with various intracorneal ring segments. Now there are two main prerequisites as of now for corneal cross-linking. One is the thickness of cornea. For isosmolar, the thickness should be more than 400 micron, and for hyposmolar, the thickness the cornea which is between 350 to 400, that can be cross-linked. And another criteria which is important is a keratoconus progression. Now, over a period of time, various protocols have been described, starting with the Dresden, where they included the patients who had increase in Kmax of more than 1 diopter, or patients who self-report the deterioration of visual acuity, or if there is a need for contact lens fitting more than once in 2 years. Then these got modified over a period of time. In 2015, Gomes et al. Said that at least two criteria. One is progressive steepening of anterior surface, and posterior surface and the corneal thinning. So any two of these criteria, if they are present, then the individual should be cross-linked. So documenting the progression is important. But also they gave some exceptions that where there is a perceived risk of progression of keratoconus, in those cases you can go for corneal cross-linking without any documentation of keratoconus progression. So what if there is no documented progression? If an individual comes to you like this with one eye having a corneal hydrops and other eye having advanced keratoconus, but within the range of corneal cross-linking, then you do not need to wait for documenting the progression. This is the OP scan of the same patient. In the right eye, nothing is recorded. In the left eye, the thinness package is 399. You can straight away go for corneal cross-linking rather than waiting for documenting any progression. So similarly, this patient, as you can see, the thinness package in this case is 355. So if you wait for any progression or documenting keratoconus progression, then it will go beyond the safe limits of the corneal cross-linking. So in these cases, you can go for corneal cross-linking straight away. In this patient, the package is good enough, Kmax is not very high, so you can wait for documenting any progression of keratoconus, and if you document any progression over say 3 to 6 months period, then you can go ahead with the corneal cross-linking. In this patient, one eye is 411, other eye is 530. So you can go for a isosmolar cross-linking in the right eye and wait for progression of keratoconus in the left eye. This is a Cyrus photograph. So in this, you can see in the left eye, it's already between 350 to 400. So no need to wait for any documenting the progression. You can straight away go for cross-linking in the left eye, followed by the right eye. So these factors you need to consider whenever a cross-linking is being done. And these are the various protocols which are followed with regard to riboflavin delivery, the UVA amount of exposure and oxygen delivery. Thank you.
Thank you, Dr. Vijay. It was very nicely and very crisp presentation that in what cases you should do cross-linking, wherein you should wait for documentation of progression, wherein you should not wait for a proper documentation when you already see that it's already advanced in the other eye, somebody has developed acute eye drops, etc. All these factors are there wherein you can directly go ahead and do cross-linking. Anything, any age-related criteria which will you consider in, waiting or doing directly?
In younger children, usually the risk of progression is quite high. And in younger children, but the problem is then you may require general anesthesia. So you have to balance both the things.
Absolutely.
If you can, you have to balance both the things for the kid. If you're documenting and it's progressing very fast, then you can go for early corneal cross-linking in children.
Yeah. Another thing which I would like to, hear from you is that somebody who is coming for the first time to us in the OPD with, sort of advanced keratoconus, 424 thickness, etc., who is 430 microns or 440 microns, somebody who is 35 years of age and coming to you directly, or somebody who is 15 years or 18 years of age coming directly to you. So in which condition you would like to wait and which condition you would like to go ahead directly with cross-linking? That is one thing. And another point I would like you to emphasize on, in children, if you have VKCs, then, whether we should go ahead directly or maybe treat VKC for some time. Because the outcome of cross-linking may not be the same if somebody is having VKC. So that is something which we all should consider. A child with a VKC should be treated first because the outcome of CXL is not that great if somebody is having VKC. But and somebody who is say 18 years of age coming to you for the first time with a corneal thickness of 440, 18 years of age, you may consider if the other eye is having all those problems which Dr. Vijay was telling. Somebody who is 35, 38 years of age with that much of thickness, one may consider waiting and seeing whether it is progressing or not. So, I mean, we have to weigh the benefit, we have to weigh the chances of progression which is there or not. All these factors we have to think. Any comment?
Yeah, I would like to know, I mean, how long, what's your criteria for repeating CXL in a patient that has progressed in spite of CXL, let's say, done, or is there any you wait for? Is it the same as the primary criteria?
Usually, you can prioritize it as per the individual. If you're finding that keratoconus is progressing very fast, then you need also to know that is there any other offending factor that is causing this keratoconus to progress very fast. Like sir told, in VKC, if you do not treat VKC, individual keep on rubbing and keratoconus will keep on progressing further. So all additional these things need to be treated. Criteria, otherwise we follow the same criteria. And there is no fixed criteria for repeating the CXL, but you can prioritize as per individual requirements.
Thank you. Is there any question from the audience?